Firstly, thanks everyone for joining us for what is our third instalment now of this ongoing webinar series we're going to run monthly, touching on various conditions, foot types, different shoes, footwear, etc. So for those of you who are jumping in for the first time, Kay Wilson's my name, Managing Director of Orthotic Laboratory. Today we're going to touch on 4 conditions, and we'll try and do that in sort of 25 minutes so you guys can get back on with your day. So we're going to touch on Morton's Neuroma, Midfoot Osteoarthritis, Freiberg's disease, and Metatarsalgia. Because they're all midfoot and forefoot conditions that we sometimes recommend carbon fibre spring plates for, I'm going to spend the first couple of minutes just touching on the carbon fibre spring plates so that people understand why they're beneficial for these conditions. Some of you will have, and if you don't, I do recommend looking at our carbon fibre spring plate diagnosis pack. It looks like this here. It's 4 different carbon fibre spring plates. It's about $360 worth of carbon fibre spring plates for $90. And the benefit of those is that they stay in the clinic all the time. And if somebody comes in with midfoot Neuroma, plantar plate tear, hallux rigidus, hallux limitus, even hallux ulcers they're being used for, you can put it in the patient's shoe, get them to walk around and see if it's beneficial before you utilise it. How they work for these midfoot and forefoot conditions is that they offload the flexion metatarsal heads, offload the midfoot, and aid in propulsion going forward. So I'll just share my screen and I'll jump into just our educational website off the portal and go into our prescription guides. So there's a couple of different models. The ones that we use for the diagnosis pack are what we call our straight plates. So they can be used left or right, flipped over. So somebody comes in with a left foot issue or a right foot issue, you can use the same plate, put it in their shoe and see if stiffening up the shoe and creating a toe spring assists. The diagnosis pack comes in extra small and medium. You can fit a medium plate into a size 12, 13 male foot or shoe, I should say, and they'll experience that stiffening up and the toe spring. However, if the plate's too big, it won't get into the shoe. So we do offer them in smaller ranges in that diagnosis pack. The straight are good for low-pitched shoes, but as you can see on the plate there, it does have left or right on it. The tapered ones offer a better toe spring, so they've got an elevated heel of around 10 to 15 mil and an increased toe spring through there. So they aid in that propulsion and act as a bit of a rocker bottom sole. And then we also do custom shaping, Morton's extensions, out-toe gate plates, plantar plate tear modifications. So anything that you can think of, we can customize it for you. So at the bottom of each of these template scripts, it will have a carbon fibre spring plate may benefit this condition, and that's why it just acts as a rocker bottom sole, aids in propulsion forward and offloads midfoot and forefoot. So we'll start with Morton's extension. So we're going to talk about 2. One's got a 2 to 5 step in it, and one's got a pontoon. So what we're trying to do is increase the space between the metatarsal heads, often between 3 and 4 mainly, offloading unnecessary pressure, add cushioning to the device, and if need be, assist in propulsion, and that's where the spring plate comes in. So I'm going to go through the 2 different ones to give you some new ideas. I'm just using our internal portal. It just gets me in there a little bit faster. For those of you who haven't jumped in on one of these webinars before, it's very difficult for us to tell you what rear foot correction to do. That's going to be based on supination resistance, Jack's test, where the subtalar joint axis lies. So if you're looking at a medially deviated subtalar joint axis, this sort of foot type, then you've got to get higher rear foot control and change the design. We do run webinars on the different designs, but what we've used for most of the conditions here is our most common, so 4-degree moderate part first ray fill, which allows the first ray to drop, windlass to kick in, and allows for first ray function. So moving away from that, what are we looking to achieve with the 2 to 5 step Morton's extension? You don't really need any intrinsic modifications unless it's specific to that patient. Don't really need to look at poly-X or composite over 3D print, so whatever your preferred shell material is. And then it's not until we get down into the low profile met dome, what are we trying to achieve here? With people that haven't worn orthotics or had met domes before, we generally recommend starting with a low profile met dome. They're better tolerated, especially for an overpronated foot or a pes planus foot type. As you get into your capewood feet, then your full height met domes tend to be tolerated quite well. If you're looking at high-heeled shoes, then we generally recommend a full height met dome because you're not necessarily standing on the met dome. You're sort of positioned in front of it, and the met dome's pushing forward as opposed to up, and it's just more comfortable. We've positioned it 2 to 4 because we're trying to push the met dome up into metatarsal 3 to create spacing between 3 and 4 in the Morton's neuroma, which is most commonly where that neuroma sits. So we're adding cushioning through to the sulcus, so that's just to add some cushioning beneath the metatarsal heads. And then the 2 to 5 step does 2 things. So if we have a look at the image, just go into the educational website off the script, and then into the 2 to 5 step. A couple of things that we're doing. So we've got a low profile met dome sitting on top of it, and what the 2 to 5 step does is just broadly pushes that met dome higher up into the metatarsals themselves. So it tends to be a lot more comfortable than using a higher, more prominent met dome. So just push the metatarsal heads up and then use a lower profile met dome. So that's the first benefit that 2 to 5 step offers. So what a 2 to 5 step is it's blended onto the shell. It runs to the distal edge of the shell and then bullnoses off pretty quickly. So you end up with a 2, 3, 4 mil drop off at the distal edge of the orthotic. So the benefit that has in Morton's neuroma, and it can transfer across into sort of, more broadly metatarsalgia if there isn't an underlying diagnosed pathology there, is that it actually lifts the metatarsals off the ground and therefore takes the pressure off the metatarsal heads itself. So that's the idea behind that 2 to 5 step. We do it out of a firm EVA because you're dealing with a firm shell underneath. And so we want to create a firm elevation of met heads 2 to 5 with that met dome on top. 3 mil tends to work well. 2 to 4 wouldn't be uncommon. 5 would be pretty excessive, and 1 isn't going to do a whole lot. And then we're getting into just adding some soft cushioning. So, you may push that up to 3.2 if you've got room in the shoe. We've done a soft EVA. 2 or 3 mil is really going to come down to how much room you have in the shoe. And then at the bottom of these scripts, you've got an Orthotic carbon fiber spring plate may complement this prescription along with the types and the sizes. So you can order it on the script portal, or you can just get rid of the spring plate underneath. So if we jump back into the other Morton's extension template, and for those of you who haven't seen our portal, you can type anything in here. Alex Rigidus, turf toe, whatever you can think of, it's generally going to be in there, including R.M. Williams boots, because someone wanted a prescription for an R.M. Williams boot. If we go back to Morton's extension, the pontoon. So the pontoon is more about splitting the met heads. So you've got 2 and 3, you want to actually split them to create space between those met heads. So again, the rear foot and design comes down to the patient's foot type. Again, we're not really getting into much until we get down into the additions here. So we've got the Met Dome low profile again. This time we're gonna push up centrally under the third Met head. So PMP to sulcus again. We're cushioning that the plantar surface of the Met heads, and then in the notes, we've got third metatarsal pontoon. Now, some people do U-shaped cutouts for offloading neuromas and things like that. I think it's a short-term fix if you're trying to increase the space between the metatarsal heads. Allowing them to drop into a hole is essentially, you're decreasing that space. Oh, hang on. Wrong. Sorry, let me go. What am I looking for? Third metatarsal pontoon. So if you go to the education website and you go to orthotic additions, you've got the 28 most common additions that are listed in the drop-down box, but you've also got Met domes and additions in notes. So pontoon is an addition in notes, and essentially that is what it looks like. So it's just an elevation of the third Met head. So if you've got impingement between third and fourth, elevating that third Met head, allowing the second to drop a little bit, but you've got a Met dome underneath it so it doesn't drop too far, also tends to work really well for the neuroma patients. Let me just see. Feel free to post any questions and I'll either answer them after each condition or at the end, but I am mindful I've got to get through two more in the next 10 or 15 minutes, so I might answer them at the end. Right, so let's look at midfoot osteoarthritis. So we're trying to prevent, excessive and uncomfortable movement through, pretty complex structure of joints. And what we know works well anecdotally is that if we limit both inversion and eversion, cushion the orthotic, and then possibly aid in that propulsion with a spring plate, then we go a long way to making it a lot more comfortable. So the way in which we do that is we want to invert the rear foot to some degree. And so inverting the rear foot and supporting the MLA is going to prevent eversion of the foot. However, it doesn't deal with the inversion of the foot. So what we're going to do there is either do an intrinsic forefoot valgus. So you can see an intrinsic forefoot valgus there. So that's going to limit any excessive inversion of the foot. So invert the rear foot, evert the forefoot. It's going to minimise medial and lateral movement of the foot to some degree. And that prescription there tends to work quite well. In saying that, that's an intrinsic forefoot valgus. So if we go through to the educational website and zoom out. So you can see that's your intrinsic forefoot valgus there. It's like a bull nose down behind the fifth Met head. If you're limited for space, dress shoes, business shoes, that's probably as good as you're going to get with your forefoot valgus. However, if you can run an extension into the toe box, either a sulcus length or a full length EVA extension, then you're going to just control that over a longer lever, control it into late mid stance and toe off. And anecdotally, we find that works better. We've gone for Poly-X here only because Poly-X is a little bit more forgiving than PA11. So it's, again, you can jump into the educational website, have a look at pros and cons, rebound and compression timing. So it flexes a little bit easier, returns a little bit slower, tends to just be a little bit more forgiving with your OA patients. Alternatively, you can look at EVA, which is softer again. I wouldn't tend to be recommending PA11 or composite for those patients. We're sort of trying to decelerate pronation. Your Poly-X is a much better material. And then the other things we're looking at doing, so we've addressed we've limited the inversion and eversion of the foot. So we want to add some cushioning. So that's your forefoot valgus, which again, if you're unsure what that looks like, you can drill down into these pictures here. Forefoot valgus to sulcus, and then there you blend lines. So it's this is almost 0 under the second, full thickness under the fifth. I think it works even better if you can do a full length forefoot valgus. As I said before, carries all the way through, but you may or may not have the room in the shoe to do that. And then again, try and put some cushioning in there. So 3.2 mil pour-on, shell and extension, 3 mil neoprene. Keeping in mind that you do need to have the appropriate shoes there, because if you've got a 3 mil EVA forefoot valgus plus 3 mil pour-on plus 3 mil neoprene, you're up to 9 mil in the toe box of the shoe. So you may need to wind some of that back. And again, we've got the carbon fiber spring plate recommendation, which I think for this and for Freiberg's is probably the most important. So if you've got severe midfoot OA, it really does help in that propulsion forward, the spring plate, the toe spring, and Freiberg's disease, which we're going to move on to next. Oops. So Freiberg's disease. So here we're trying to, I guess, elevate the second metatarsal head. Start again. We're not trying to elevate the second metatarsal head. We're trying to elevate the second metatarsal, offload the second metatarsal head, and again, stiffen up the shoe and give that toe spring. Again, cast modification and rear foot comes down to the patient's foot type. So no other real intrinsic modifications are needed here. I don't have an opinion on 3D print versus or PA11 versus PolyX versus composite. We're not trying to sort of decelerate pronation or anything like that. So it really gets down to what we're doing here. So the Met bar is going to give a gentle elevation to all Met heads. So the Met bar, as opposed to the Met domes, are a little bit broader and a little bit flatter. So if we zoom in, there's sort of the shapes of your Met domes, which you'll be familiar with. That's your Met bar there. So it's really only 5 and 1 that aren't supported, and it's the top of them are flat. So these are the kidneys are domed, the Met domes are domed, whereas these rise up, flatten, and then bullnose down at the end. So you're just lifting that second metatarsal fourth off the ground with Freiberg's. U-shaped cutout, so we're not allowing that Freiberg's to sink in or drop, because we're elevating it with the metatarsal dome. And we're going to do another elevation in a moment called a second metatarsal step. So your U-shaped cutout will be sulcus length. Pretty self-explanatory, but so U-shaped cutout to the second. So we're just going to create that. We're going to behind it, but we're going to go one step further. And in the notes, we have a second metatarsal step. So again, it's not in our drop-down box, so you'll find it on the education website under prescription guides, orthotic conditions. Sorry, I'm zoomed in. And so there's your second metatarsal step. So what that does is supports the second metatarsal, elevates the second metatarsal, and takes all the pressure off the metatarsal head, which is obviously affected with osteonecrosis or what have you. So that's sort of it works really well for Freiberg's disease, and that's done out of a firm EVA or medium EVA. Medium or firm EVA, the firmer you go with the EVA, the more you're sort of supporting something, and we want to support the metatarsal shaft, obviously, to offload the metatarsal head. So it's almost like that 2 to 5 step where we're lifting all metatarsals off the ground, bull nosing and taking the pressure off all of them. This is specific to the second metatarsal. And again, the carbon fiber spring plate, will most likely complement this condition. You really want to, offload that flexion through the met heads, and that toe spring is really going to be beneficial. So they're relatively inexpensive, and I'd certainly be looking at it for at least trialing the patient for this sort of condition. Couple of minutes, we'll get through metatarsalgia. So I guess it's a broad term, often encompassing an underlying pathology. Not everything in the portal is a exact pathology, because people ring up and they say, well, we've got metatarsalgia, so they may be searching for metatarsalgia, just like there's cycling shoes in here. So anything that you can sort of think of will be in here. If it's not, we'll generally add it in there for you. For those of you who aren't aware of how our templates work, anything that we create is created by Orthotic. You can create your own templates, or you can take our templates and clone them and make them your own. If you agree with 80% of what we're doing, and you say, no, I like this, this, and this, you can create your own template there. So, and only they're available to the people that you've set up as users in your portal. I guess without knowing the exact pathology, so it could be a plantar plate tear, or it could be a neuroma or something like that. Then the goal here is basically to support the metatarsals, offload the metatarsal heads, and cushion them. So again, can't tell you exactly what rear foot and midfoot to do, patient specific, foot specific. And so we're just getting all the way down to, again, met dome. So we've done a low profile met dome. So I'll just quickly touch on before. If a patient hasn't had a met dome before and they're an overpronated foot or a pes foot type, then basically that met dome is often going to feel quite prominent. So we would recommend, if they've never had met domes before, to start with a low profile. You can always increase it, but there's nothing worse than giving your patients orthotics that they find uncomfortable. The exception, as I mentioned earlier, would probably be your cable feet or high arch feet, if they don't have as much pressure and you need a larger dome to get into that space, or high heels where they're not really standing on the dome, they're actually standing forward of the dome, and you're trying to push into that space. 2 to 4 spacing. For Morton's neuroma, just going back a little bit, sometimes people go 3 to 5 if you want it sitting under met head 4. But as a general rule, we tend to find they're more comfortable and work better if they're centralised, and they will hang 10 millimetres thereabouts over the distal edge of the shell. So you can ask for that to be 50% on, 50% off, or some people push it 75 or even 100% off the shell, but you're getting right underneath the met heads when you do that. Cushioning, PMP to sulcus out of slow release boron. 1 to 5 step is optional. We'll put it in there because it's a good thing to think about, especially with a low profile met dome. So we touched on it earlier. 1 to 5 steps. So it's a broad drop off at the end of the shell. So we're basically thickening up the end of the shell. So we blend it back on, and you might have a full thickness of 3 mil there. So if you can imagine, you're kind of lifting all the met heads off the ground and then putting a low profile, comfortable met dome on top. So that is really well tolerated, the 1 to 5 step. Some people will do that without the met dome, but you can imagine if you put a low profile met dome on there, you're just pushing a subtle dome up into where it needs support. And again, carrying on with the cushioning, I'd be looking at, the 1 to 5 step, again, medium or firm EVA. to help push that midtone up into the space, and then add whatever cushioning you can. Most of these conditions we've gone with the soft high performance EVA and some Poron. You can increase that if you've got the room in the shoe, but keeping in mind you do have a 3 mil slow release sulcus length PMP. So this prescription would be 3 plus 1.5 plus another 2. So you're looking at 6.5 to 7 millimeters underneath the metheads, which is about what most shoes can fit. Again, if it's severe, then you may look at a carbon fiber spring plate. So we do have it in there. As I said before, it's probably more important for Freibergs and midfoot OA, but it's something to consider for Metatarsalgia and Morton's Neuroma as well. All right, how did we go? 25 minutes. That's what I was aiming for. So I'll stop sharing this now, and if there's any questions, you can pop them up here, or you can always reach out via email or give me a call as well. There's no questions. Thanks for attending, guys. I'll hang around for a couple of minutes in case there are some, and we look forward to it. Oh, there is a question. All right, it's on the wrong section. The Freiberg's pads, what order do you place the 4-foot pad in? So I always have the softest layer against the foot. So I'd be going shell, then second metatarsal step, then the metdome, then the Poron. So that's the way in which we would build it. But you can specify, another way if that's your preference. Well, hopefully we see you at the next one, which is I think early September, I believe. Keep an eye on your emails for the conditions and the dates. I know some of you have already signed up for it because the rest of the year has been set. Thank you for your time, and thanks for coming.